Hey guys, it's June 16th, 2021. This is actually going to be the lesson for the PTA200 class. Sincerely apologize, I'm not there with you directly, but I'm here, right? We're going to get through this. I'm going to do most of the lecture or the didactic portion of the lecture before we kind of talk about the techniques of joint mobilization. On joint mobilization today, probably be a shorter lecture than normal, but again, the class is only an hour and a half anyway, normally. And then tomorrow when we have Kenise, we'll actually get into kind of talking about how to physically do the joint mobilizations. And obviously when we're back on campus, we'll go ahead and actually do the joint mobilizations. That's kind of the plan from here till there, till whatever. So that's where we're at. We're going to start talking about joint mobilizations today. I really am glad to still do this lesson. I apologize again, I'm not there, but we're doing some pretty exciting stuff on the other side of things, getting ready for test prep. So I had an unfortunate meeting that I have to attend for that. So, I mean, I'm sure you guys are real sad that you didn't have to sit in lecture from 1 to 5 today. But c'est la vie, we're going to get along with it and get going here. So we're going to talk about joint mobilizations today. So one of the major things that a lot of people ask me is, well, Mr. McKeever, this is the PTA200 class, and it's on joint mobilizations. But joint mobilizations are really in the Therax book, the Kistner and Colby book, and the Borstad. I guess I got to add Borstad to that now, the 7th edition Green Book. And like, yeah, you're right. They are in the Kistner and Colby book, but the technique of joint mobilizations and arthrokinematic, osteokinematic technique. So that falls under the kinesiology umbrella. So when the curriculums were designed for most PT schools, the joint mobilizations get taught under this kind of umbrella, under the kinesiology umbrella. I'll be referencing your Therax book. You have that, chapter 5, but the actual details we require for your PTA 200 class. This is just to clarify confusion. Also, understand the evidence-based practice for mobilization, the literature is all over the place. And remember, we have that kind of pyramid where we've got that evidence-based practice, where we've got that researched material, but we've also got clinical practice as well holding up that pyramid. And so in this case, you know, I myself have had a lot of good results with joint mobilizations, but other clinicians haven't. So there's very little in the way of randomized control trials. There are some case studies, there are small cohort studies, stuff like that, but the literature itself is very mixed. The other thing to kind of remember here, and this is key, we never use the term manipulation, especially in Nevada. We can use mobilization, we'll use glides, we use everything like that, but manipulation is out. Manipulation is a chiropractic only term. So please do not use that term even in the clinic. It can open up the PT profession to all kinds of problems. We just don't want that. So kind of reviewing some basics on this, right? So manual joint mobilizations are manual therapy techniques that use modulation of pain and treat joint impairments that limit range of motion, specifically by addressing the altered mechanics of the joint. That capsular pattern, right? That's an altered joint mechanic that's not normal, so we're going to use mobilizations to get through it. So we have the term mobilization and manipulation. They really mean the same thing, okay? It's just a legalese that we don't use manipulation in Nevada. And especially what we call HVT, or high velocity thrust. Those are the grade 5s that we're going to talk about. Those are specifically PT only. There's also self-mobilizations. And when I say self-mobilizations, literally patients can do mobilizations on themselves. So for example, I'm going to do one just as a brief kind of thing. I'd rather have a golf ball, but this is what I have. I can place that up here in my kind of suprascapular fossa, get that in there. Now let me get the sling over my back here. Get that nice and in there, get the towel over it. Right, and this towel's not gonna work very well because it's not very firm. But I can get it in there and I can pull this towel down. This one won't work because it stretches. I need a towel that doesn't stretch. And I can mobilize my first rib with this ball. Self-mobilization, right? So not all mobilizations are going to be done in the clinic, but just as easily, let's see, can I get a good one? There we go. there's one little one. There we go. I got a little one out in the end. Those are self-mobilizations. Cracking your knuckles, self-mobilizations. We talked briefly about mobilization with movement, and that's where we're going to incorporate a movement-based activity along with our mobilizations. Remember, we have that kind of physiological movement, the osteokinematics bone on bone, plus the accessory movement, the component motion, where we have that joint play going on, the arthrokinematics. We can do manipulation under anesthesia, and this happens quite frequently, especially in the case of something like a patient who's had a total knee replacement and does not adhere to their program. So now they're stuck and they're only getting 20 degrees of knee flexion. The doc can put them under anesthesia and then do a mobilization while they're under anesthesia in order to improve that joint motion. And there's also this muscle energy technique. I know a couple of you have asked me about this. And again, I'm not trained in muscle energy technique, so please don't think I'm a specialist in this. But muscle energy technique is a combination of joint mobilizations along with some PNF movements, which we'll talk about in PNF. So it's kind of some fundamental principles. When joints are normal, the joint moves without limitations. The strength and the resiliency of the capsular tissue and that periarticular, the stuff around the tissue, is maintained via joint movement. The more you move, the less you are likely to get a capsular problem. Immobilization, so we get injured and we stop moving, that starts a cascade of negative consequences. So mobilization itself refers to an attempt to restore a joint motion or mobility to decrease pain with associated joint structures. Pretty simple. It is a passive, skilled manual therapy technique, meaning that we have to be trained on it before you do it. This is not something your CI goes, well, do you know how to do a spinal mobilization? I'm like, sure, let me figure it out. No, you can actually hurt a person that way. You need to be trained on it in order to be able to do this. There are varying speeds, varying amplitudes, meaning depth, right? With physiological or accessory motions that go along with it. So we have our normal range of motion that goes along with our flexion, abduction, adduction, internal external rotation, horizontal ad, horizontal ab. All of those go along with it. But when we have that capsular pattern, we're limited in that specific pattern, that's when we can go ahead and do these joint mobilizations. That osteokinematic degree, it's almost like we're beating this because you need to know it. Osteokinematic is our classical bone-on-bone movement, the bone movement at the joint. It can be visualized by the naked eye and measured by goniometry. It occurs in our cardinal planes of movement, such as frontal, sagittal, transverse, right? So hip, knee, shoulder flexion movements are all under volitional control, meaning we can control them. It's a gross movement of the shafts of the bone, again measured by goniometry. We have active range motion, which can be limited by contractile tissue. And then passive range motion, which is typically greater than active range of motion. And they're not going to contract with that. There is a thing called that end feel. That's that feeling that's experienced by the examiner at the barrier of the range of motion, right? That does require hands-on experience. There's normal and abnormal end feels. We talked about those ad nauseum, bony, hard, soft, boggy, all those fun end feels, empty. We're not going to hit them again, but just know that goes along with that osteokinematic motion. Our arthrokinematic motion is kind of the joint surface movements. It's movements that occur at the bone ends without regards to the movement itself. These are not under volitional control, meaning that you can't 100% control these while you're doing it. It's known as accessory movements, and it involves motion specific to the articulating joint surface, right? Sometimes referred to as roll, spin, glide. Sorry, I was up way too early this morning. Again, it's usually referred to as accessory motion in the joint or clinical setting. We don't call them, whoa, you have arthrokinematic motion, sir. No, we call it accessory motion. Component movement, joint play, joint mob, joint manipulation all comes into play with that, right? We've talked about swing, spin, roll, slide, combination spins, all of that. That convex concave rule comes into play here. All of that ties into the arthrokinematic motion, right? There's our convex concave rule. It's a rule for determining the motion, and we need to understand that in order to know what direction to mobilize the patient. When a joint is congruent, the surfaces have maximum contact with each other and are tightly compressed, meaning that they're as tight together as you possibly can get. They're difficult to distract, and they are in the closed packed position. So when they are approximated and congruent with one another, meaning as close as they can get to one another, they are closed packed. In all other positions, joint surfaces are incongruent. So we talked about in the ankle, dorsiflexion, full dorsiflexions are closed packed position. But we mentioned that the open packed is somewhere between, well, about 10 degrees plantar flexion, somewhere between inversion and eversion, somewhere between supination and pronation. Anywhere other than the closed packed position, you can mobilize a joint. It's just the most effective place to mobilize a joint is in that open packed position. So again, which joint position is most suitable for joint mobilizations? The open packed position. Open packed mobilization, closed packed stabilization, mobile, stable, mobile, stable, mobile, stable. I'm just going to beat that into you guys, hopefully by the end. So passive angular stretching versus joint glide stretching, right? Passive angular stretching, when we do normal stretching, may increase joint trauma or pain. Joint glides or mobilizations are usually safer and a little bit more selective. We don't do as much movement when we do a joint glide or joint mob. Honestly, most of the time it's a few centimeters of motion. It's not even like 6 or 7 inches. We'll combine compression with it when we push stuff together and traction where we pull stuff apart. So traction is typically longitudinally, length of the body. Distractions where we really kind of pull stuff apart, right? So traction you think of when you do the spine. Distractions when we pull the joint surfaces apart. We're going to combine that while we're doing joint mobilizations in order to increase the joint play of the joint. So why do we do it? Well, it helps move synovial fluid. The more we move synovial fluid, the more the cartilage gets bathed. The more the cartilage gets bathed, the better the joint articular surfaces become. It helps maintain extensibility and tensile strength of the articular and para-articular cartilage tissue. So all of those tissues that are in that area, the more we kind of stretch them and work them, the more things function better. Provides sensory input for important balance response. So it'll help the patient understand better their balance deficits. Had a red light on, I didn't like red light. It made me feel like we're stopping. It improves bone marrow production. And at any movement, we know this. Anytime we get a patient up and moving, it improves bone marrow production. And that stimulates stem cells, which can help the calcium absorption of the bones, which helps the bones grow stronger, which also helps the blood cells grow. So any movement of the bone is a good thing. So why do we do, or what's our indication of joint mobilization? I've said this before, and I will say this again till I'm blue in the face, or at least blue in the shirt. Capsular patterns get mobilized. Anything other than capsular typically doesn't get mobilized and will be stretched or strengthened. Patient safety is always considered first. If they're not comfortable with you doing joint mobilizations, don't do them. If they are guarding, resisting while you're trying to mobilize the joint, you're not going to be able to mobilize it. Extreme caution, and I would hasten to say I kind of watch really closely at really early trauma surgery or patient mobilizations to not do joint mobs. There are indications for it, but you really have to be a skilled clinician so that you don't really cause some serious trauma to that already existing trauma. Pain is a relative indication for joint mobilizations depending upon the stage of tissue healing. We can use mobilizations to reduce pain, specifically grades 1 and grades 2, which we'll talk about. Absolute contraindications, meaning no questions, stop, do not pass go, do not collect $200, is osteoporosis of that joint, being that that joint is severely compromised. Rheumatoid arthritis, because when we have a rheumatic joint, we can really seriously damage things. Joint hypermobility and other neurological symptoms. When we have pain, guarding, and spasm, we kind of have to treat those by first relaxing that information or relaxing that body, getting a neurophysiological effect in order to get our mechanical effect. We can't necessarily mobilize it if they're guarded with pain or whatever. If they have reversible hypomobility or progressive limitation, it's an indication for joint mobs. Positional faults or subluxation. So maybe I've got a slight sublux of the shoulder where it kind of dropped out, but it's not really. I can use joint mobs to kind of get that back into the proper place. And then functional immobility where, maybe they just aren't able to move as much. Some limitations and some precautions, contraindications. We cannot change the disease process. If they have osteopenia where the bones are wasting away, can't stop that. Can't change a chronic inflammatory process. If they're in a constant state of chronic inflammation, can't really change that. And the skill of the therapist comes into play here, right? So hard contraindications, precautions are hypermobility, joint effusion, meaning lots of swelling in the joint. Inflammation we talked about, irreversible hypomobility, meaning bone is fused, can't mobilize it. Pregnancy, especially at the late stages where that relaxin chemical or hormone is traveling through the body. If that's traveling through the body, that can seriously make those joints super loose and loosey-goosey, and you can tear ligaments. Malignancy, specifically in the area that you're mobilizing. You don't want to mobilize cancer because if you mobilize it, it spreads. Any specific bone disease that is detectable by an X-ray or a radiograph. An unhealed fracture, specifically one that's either unstable or comminuted, you definitely don't want to do mobilizations on them. And then hypermobility with associated joints. So if I'm mobilizing the shoulder, or say the scapula, I'm doing scapulothoracic mobilizations, and the shoulder is really, really hypermobile, I might not want to mobilize the scapula at that point because that could seriously conflict and cause damage at the shoulder. So procedure for applying a passive joint technique. Well, first of all, the PT has to examine and evaluate them, right? They're going to evaluate the quality of pain, the capsular restriction, and if there's any subluxation or dislocation that's occurring. With regards to spinal mobilization, the APTA says interventions exclusively performed by the physical therapist include interventions that require immediate and continuous examination and evaluation throughout the intervention. Such procedural interventions within the scope of the physical therapist's practice are performed exclusively by the physical therapist include, but are not limited to, spinal and peripheral joint mobilizations manipulations, which are components of the manual therapy, and selective Sharps debridement, which is a component of wound management. That was House of Delegates PO00 or PO6003036. So that was one of the rulings they had. So that literally says we can't do joint mobs as PTAs. So by rule of the APTA, we can't, but I'm here to tell you we still do joint mobs as PTAs. They kind of left it up to the states to decide what the states want to do and what the states don't want to do. And so primarily the states say no spinal mobs, no grade 5 mobs, and some states will even say no grade 4 mobs for PTAs. In my state, back where I'm from, Pennsylvania, we made a distinction and said that PTs can do joint mobilizations, PTAs can do joint glides. The grading and the management system was all the same. We just didn't make any assessment while we were doing it. So if I was doing a distraction glide on the wrist, I would put nothing in my assessment about it. I would just indicate that I did mobilizations or glides of the wrist, and that was it. I would never indicate that the patient had an improvement with that, a non-improvement. That's where they kind of say that's more of a PT skill, is analyzing if the joint mobilizations are working. So again, semantics, sure, but it's semantics for a reason. So when we talk about joint mobilizations, we have 4 primary grades that we may be able to do, and then the 5th grade, which is not us. So let's talk about the 5th grade first, get that out of the way so that we're never there. A 5th grade or a grade 5 mobilization is a thrust mobilization. That's that quick pop, small amplitude, high velocity, performed only once. It is used to snap adhesions and reposition joint surfaces.
My apologies.
So that is when we maybe do a thrust mobilization of spinal cracks, right? The spinal cracks of the neck. Or even, you're popping your thumbs and your fingers and everything like that, or I'm going to pop my toe or something like that. That is a thrust manipulation. We do not do those on patients. I'm going to stress this again. We 100% do not do those on patients. If you have a clinician that's your CI that asks you if you would like to learn them, you can sit and watch. You can watch them do it. You can see how they do it. You can learn techniques, meaning that they can say, this is the way I do it, blah, blah, blah. You may not get hands-on and do that. Grade 5 is out of our scope of practice, and that is a violation of practice. Do not do grade 5s. So then what I want you to do right now is if you have something soft, like a pillow, or in case of me, I've got this nice soft ball here. I'm going to use that as an example on how to determine what is a grade 1 through 4. So what I want you to do is take that item that's soft and squish it as far as you can squish it. All right, so you know how far you have a range of motion, right? You can't go any further there. And actually, I'm going to pause and grab a pillow because it's a better example. So give me 1 second. Should have brought one back with me. I'm just going to pause recording. I will be right back in 1 second with a pillow. All right, that 1 second's up. I have my pillow now. So I just got a normal kind of neck pillow here. So take that pillow, right? Squish it as far as you can get it squished. You know how much range of motion you now have in that joint. We're going to pretend this is a joint. All right, good. So let that joint kind of expand. A grade 1 mode is where you're literally just going to go a few millimeters at the very beginning range of motion. I am, at this point, just putting an inferior mobe on this, so just going down. I'm not pushing up with this bottom hand here. I'm just using that to support. So literally just a few millimeters of motion. It is an oscillation, meaning I'm just bouncing back and forth. That helps with pain movement and will help somewhat with fluid movement, meaning the actual fluid movement of like edema and stuff like that. A grade 2 is a large amplitude, and I like to say it goes up to about 50% of the range of motion. So if here is squished, there is about 50. So I'm going to start all the way out and go to 50. Right? We're going to go in the club. Just joking. We're going to 50%. And again, it is a large amplitude, meaning there's a good bit of travel, right? We're going to go there and we're going to stop. We are not getting any stretch at that point. All right? So at grade 3, now we are going to go up into the resistance. So now we're going to go to that 50 point and go out to my resistance point and just a tad bit into that resistance. So from the 50 point out, that is at a large amplitude. So I'm still going about 50% of the range. And then my grade 4, I'm going to go all the way out to where I've got resistance. And I'm going to do those oscillations again, where I'm kind of pushing. I'm not thrusting. I'm not doing one of those. I'm literally just putting a little bit of pressure, a little bit of pop out there. And again, that's going to stretch out that joint capsule. So grades 1 and 2, pain modulation or inhibition, fluid movement. Grades 3 and 4, stretching. 1, oscillation at the very beginning. 2, large range of motion to about 50%. Boom, boom. 3, start at about 50%, go to the end. Boom, boom, boom. 4, go to the end, oscillate again. Bounce, bounce. Bounce with me, bounce with me. And a grade 5, thrust minute. We're not going to do those. Those are against the rules. And we never want to go against the rules. So when we position the patient, we're going to position them so that not only are they safe, but it maximizes our efficiency, right? So if I have to do a posterior mobe, right, then I want to make sure that I'm doing it in a direction that's posterior, and it's easiest for me to do posterior direction, right? We want to put them in a treatment plane where we can go the target that we want. You initiate the progression of the treatment and then validate patient response. And then we go back to the beginning and just keep doing it, right? You may want to warm up the tissues first, either by doing an active warm-up or a passive warm-up like a hot pack or ultrasound, right? I tend to do a little bit of stretching, a little bit of range of motion before I do joint mobes. And then I do joint mobes, and then I do more stretching and more activities afterwards because I want to use that new range of motion I've gained. So you don't want to do joint mobes at the end of your session because at the end of the session, you're sending the patient home, and most of the times they're going home to rest. When you mobilize that joint, you need to use that new mobilization range of motion. So they need to be doing stuff, maybe just doing some simple range of motion activities, maybe getting on the pulleys, maybe getting on the bike, something to use that new range of motion. And we talked about capsular patterns. If we have a capsular pattern, that is our main reason for doing this, right? It's a restriction in all or most passive motions related to each other. They're very often limited by very small amounts. The most accurate measurement is by looking at both sides. So if I've got one side that's 45 degrees of hip flexion, the other side is 30, that might be an indication for it. Each joint has specific patterns and limitations. You are responsible for knowing those. If the limit of motion is not in the capsular pattern, we suspect other problems, strengthening, stretching. Okay, so if it's non-capsular, joint mobilizations probably aren't going to do anything. Does that mean that a grade 1 mob doesn't feel good for that patient? No, absolutely. It does feel good for those patients. But it may not be a capsular pattern at that point. Non-capsular patterns or limitations will not follow any pattern is caused by structures other than the capsule. So in case of like ankle dorsiflexion, short sitting versus long sitting, I'm able to get a little bit more dorsiflexion in short sitting where my knees are down versus on long sitting where my gastrocs are kind of stretched out, right? So that would be a non-capsular pattern. So here we're going to look at the shoulder. There's a couple of different capsular patterns here, or a couple of different motions. Capsular pattern for the shoulder is greatest restrictions in lateral rotation, followed by abduction, and then medial rotation. So I've got most in external, so going out, probably a little bit in abduction, and then maybe a little bit in medial rotation. Again, most of that's kind of where my joint's out like this, right? So we can do glenohumeral distraction, which is kind of the first part down here, where we're going to distract the joint that way. This is a caudal glide. So the glides are going to be named in the direction they go. So oftentimes it'll be an AP glide, a PA glide, an SI glide, or an IS glide. Or I've also seen SC, CI, because inferior can also be considered caudal. Okay. So an AP is an anterior to posterior glide. So this is my anterior surface of my shoulder. An AP glide or an AP mobilization would be me pushing on the shoulder posteriorly. I'm going from anterior, going back to posterior. That is also known as a posterior glide, because the simple words are the direction I'm going. I would prefer that if you're going to document glides or mobilizations, you document them by where you start to where you go. So if you're starting the posterior, going anterior, that's a posterior to anterior glide. It's also known as an anterior glide in the colloquial terms, right? So here we have a caudal glide. This would be a superior to inferior glide. She's sliding the shoulder down. Here's another caudal glide. This time the shoulder's at 90 degrees. The posterior, this is an anterior to posterior glide. Another anterior to posterior glide. We're going to practice these. Here is our posterior to anterior glide. And this one here is probably the one that everyone will love the most. I said probably ankles and then the scapular thoracic moves, because a lot of our scapular thoracic region is really tight. So when we get in there and kind of rotate those, that'll feel kind of good when we do those in person. The elbow is greater loss of flexion than of extension. Rotation is usually not affected, meaning supination, pronation, not as much. We can do distraction, which is what she's doing here, where she's pulling down on the elbow. Can do distraction with a distal glide, so she's kind of doing a U motion. Here's another distraction. There is a dorsal or volar glide where she's pushing back. That would be a posterior, an anterior to posterior glide. And here she's doing a distal radial to ulnar glide where she's kind of gliding back and forth at that radius and ulnar. The wrist has equal loss of both flexion and extension and maybe slight losses of ulnar and radial deviation. We can distract the wrist by stabilizing at those styloid processes and pulling down on the carpal bones, right? We can then do a dorsal glide where we pull up, right? I tend to push up when I'm doing it, but they could pull up. Do a volar glide where we push down, or palmar glide. We can do ulnar deviation by turning the hand like this. We can do radial deviation by turning the hand upside down. All of those are valid forms of glides or mobilization. I'm going to use the term glide because that's the one I'm most comfortable with. I apologize. I should have said that at the beginning. When I say glide, I mean mobilization. So when I say glide, you say mobilization. Glide, oh, it doesn't work when you guys aren't here. Didn't think about that. With the hip has the greatest loss of medial rotation and flexion, but the hip is a weird one where some of the books kind of counteract each other. Whereas the second one you look says, so first one says medial rotation and flexion, some loss of abduction, slight loss of extension. Another book says greater loss of medial rotation followed by less loss of extension, abduction, flexion, lateral rotation. Most of the times with the hip, what I see is if I got a medial rotation limitation and some other stuff combined with it, it's usually capsular. So I can do distraction. We're going to work on the hip using gait belts because it saves a lot of back strain, especially if you're mobilizing somebody like me. I'm not exactly the tiniest person in the world. You get on my legs are about 85 pounds each. You start lifting them and you've got somebody small like Brooke lifting those legs up, and you're going to get tired really quick. We're going to use our bodies to maximize that effect, and using gait belts can really help with that. So we've got a distraction there first, a posterior glide, which is an anterior going to posterior glide. And then the last two are two different variants of the anterior glide or the posterior to anterior glide. Here we have the knee. In the knee, we lose flexion. It's pretty much what we lose. We can distract the knee in two different methods there. She's distracting at about 25 degrees of knee flexion going down using her body weight, or she can put them in prone and distract that way. I prefer the prone method. We can do a posterior and anterior glide, which are nothing more than those posterior and anterior drawer tests we're going to talk about with special testing. The main one that we're going to hit on, and the one thing I want you guys specifically really good at when you go out to the clinics, is patellofemoral glides, removing that patella. And that we can move pretty much everywhere. We can do medial, we can do lateral, we can do superior, we can do inferior. We just can't do anterior to posterior. It doesn't work that well. That hurts. Don't push a patella back into the patellar tendon. That's just uncomfortable, especially if they got something like chondromalacia patella, where their back of their patella is all chewed up. That's just mean. Right? But if I've got something like chondromalacia patella, where the back of my patella is kind of like a serrated blade, I want to be careful about doing these moves, because as I'm moving them around, I'm basically taking a razor blade across that patellar tendon, and I can damage that patellar tendon. So we've got to be careful. This is why it's important to be trained in these before you do them. I am not going to specialize you guys in doing mobilizations. We're going to talk through them. We may practice a few. But for the most part, you are not specialists, so get over yourselves. The ankle and foot, talocrural joint usually loses more plantar flexion than dorsiflexion. Subtalar and metatarsals, loss of inversion. At the foot, usually with the big toe loses extension, the little toes not lose flexion. Yeah, the foot's a little harder, right? Well, we can do all kinds of things. Talocrural distraction is one that I guarantee a lot of you are going to like. We can do a posterior glide where we distract a little bit and glide downwards. That's anterior to posterior glide. To an anterior glide where we go anterior to or posterior to anterior. We can do a subtalar distraction where what we're doing is locking onto the talus and pulling the calcaneus. So if this is my talus, this is my calcaneus, I can lock onto that talus and use my caudal hand to kind of pull that calcaneus away and stretch out that joint space. We can do talar glides, meaning gliding that talus around on that calcaneus. And when you looked at the bones back in anatomy, you could see that they can sit on each other and kind of roll around on each other pretty easy, as long as you don't have a capsular pattern. And then there's distal tarsal glides for moving stuff around. We're also going to practice learning about cuboid, and I have manipulation down here, so I should have changed that. I'm sorry, I didn't think about that before I did this lecture. It's really a cuboid mobilization. Again, we don't use manipulation here, just because it's always been called a cuboid minute, and I got to get out of the habit of doing that. Where if your cuboid, for whatever reason, sometimes has a habit of just kind of deciding, you know what, I don't like where I'm at here on that lateral aspect of my foot, so I'm going to go down a little bit and distract myself. I'm going to change that color so you can see. I don't like where I'm at right here, so I'm going to kind of drift down on my foot. And it kind of shifts down here under that fifth met base and under that fifth met tuberosity, and kind of gets stuck. So what we can do is there's a couple of different things. We can do a self-mobilization with something like a golf ball or this ball, where I put that on the floor. I kind of get it around my cuboid, and oh God, that actually feels really good. And I'm just going to kind of bare weight down through and then putting a superior force. That's going to be an inferior, starting inferior to superior force. That's a self-mobilization I'm doing right now. And my cuboid is really kind of loosey-goosey in that lateral foot. So again, the more injuries you get to that lateral ankle, the more potential you have for this cuboid slip. Oh, that feels really good. Should feels more than it should feel good. And so you're going to want to make sure that you're on that and kind of doing that. There's what's called a J-whip with this. I will do my best to kind of explain it and show it, but I will not have you guys practicing that J-whip because a J-whip is a quick thrust manipulation. And again, what have we learned, folks? What about thrust manipulations in PTAs? Oh, that's right. We're not allowed to do them. So don't do them. So I think that might be it for the basics of the lecture. It is. So that's it for the basics of the lecture. I know that was really a short lecture, but we're going to kind of walk through doing some of these mobilizations tomorrow. My God, I am glowing with this blue shirt. It's like, oh, I have to turn that light out or something or turn it down if I ever wear this blue shirt again. So that's the lecture portion. That saves me a lot tomorrow because that means tomorrow we can just talk when we get through the Therex tomorrow, which I think tomorrow we are dealing with, what are we dealing with tomorrow in Therex? Tomorrow in Therex, which is 17th, we're going to talk about some joint bony surgical conditions and stuff like that. So once we get through that, then I can get into this for like the last hour or so. And we can talk about mobilizations and maybe even talk about some self-mobilization so you can kind of see the idea of mobilizing a joint. Again, really appreciate you. It was a quick lecture, not that much content itself as far as content that way. There's going to be a ton of physical content, meaning we're going to actually mobilize stuff. And some of you are really going to like this, and some of you won't like mobilizations. And again, not a big deal. I've had PTs that do mobilizations, and I have PTs that don't believe in mobilizations. We've just got to do what the PT tells us to, right? We are the completers of the plan. They are the creators of the plan. And again, when it comes to APTA ruling, we do not do mobilizations. Wink, wink, nudge, nudge, Bob's your uncle, right? But in the real world, most PTs in the clinic do require us to understand some basic manipulation or basic mobilizations, glides, right? And most of them, we are specifically supposed to know why a PT might be doing a mobilization. Okay? So that's it for this lecture. I'm done rambling. If there are any questions, please feel free to message me. Otherwise, I will see you guys tomorrow at 1 o'clock. Again, I apologize. Wasn't there. Got to get to the meeting right now. So have yourselves a good day. I will catch you all tomorrow. This is almost perfect timing. This is Captain Picard signing out. No, just joking. This is Mr. McKeever. I will see you tomorrow.